A quick break here. And so for our second speaker of the day, it's my pleasure to introduce Dr. Chloe Gottlieb, who is a uveitis and medical retina specialist at the University of Ottawa Eye Institute. She has a number of roles in our department, which include assistant professor, residency program director, but also the vice chair of education in the department. And she's also plays a very large leadership role in uveitis in Canada. And so it's a real pleasure for us to have her speak on this topic, which can sometimes be intimidating for trainees, and hopefully provide us with some really valuable information on this important topic. So without further ado, welcome Dr. Gottlieb. And so Dr. Gottlieb, I can't quite hear your audio. And I should also mention that I think Dr. Gottlieb told me that, the weather in Ottawa is quite crazy right now. And so hopefully we don't run into any connectivity issues.
Can you hear me now, Cody?
Yes, that is perfect.
Oh, okay, perfect. So I wanted to thank you so much for the kind introduction and also for inviting me to speak to you today. Honestly, I don't think uveitis is intimidating. I think it's a wonderful specialty that kind of merges medicine and ophthalmology perfectly well. I actually live, eat, and breathe, sleep, do whatever. Everything I do is related to uveitis. I absolutely adore teaching it as well. So I'm really happy to be here today. And we're going to go through our objectives. But first of all, I wanted to show you a couple of slides of our recent graduates. And as residency program director, I take care of this lovely group of people and their education. And it just is such a joy to do that. And this is our recent Laser Max staff and resident event. So hopefully at one point, some of you who are interested in ophthalmology can join us in our program. And we do surgery together and have excellent patient outcomes in our program. So the objectives for today, based on what Cody has provided me, is to talk about the red eye and take a focused history specific to uveitis. We'll talk about HPI, past ocular history, and medical history, and then talk a little bit about examination techniques as well, and causes of a painful red eye in the context of uveitis, and then look at a couple of really important not to miss diagnoses and some other common and uncommon causes of uveitis. So what is uveitis? It's a funny word, but it means intraocular inflammation, and it's inflammation of what the structure of the eye is called the uvea, which is the front part of the eye, the ciliary body, the iris, and then the choroid in the back. So those three structures are primarily thought to be involved in intraocular inflammatory diseases. So we prefer to actually call it intraocular inflammatory disease because uveitis encompasses this concept that it's autoimmune in nature and it's solely intraocular inflammation. But you can get inflammation in the eye and external parts of the eye, like the sclera and episclera, and even the extraocular muscles and the orbital space as well. So ocular inflammatory diseases are really the eye and the adnexal structures of the eye that can become inflamed. And it includes everything except optic nerve inflammatory disorders. So we kind of separate those out and include those in a different category, and generally orbital diseases are not included either. So here's a basic diagram of the eye, and you can see the sclera, the ciliary body, vitreous humor, and the optic nerve at the back. But mostly we'll talk about anterior uveitis today, involving the iris and the ciliary body. In 2005, which is a long time ago, but this is still valid as a teaching point, the standardization of uveitis nomenclature was published by the International Uveitis Study Group. And so they really helped form a language that we use for uveitis and a categorization system or classification system. So you can see here, it's classified as anterior, intermediate, posterior, or pan-uveitis. So looking at that a different way, anterior uveitis involves the anterior segment, the iris, the ciliary body. Intermediate uveitis involves the middle structure of the eye, which is made up of the vitreous humor, and it contains collagen fibers and other inflammatory mediators, and surveillance of the immune system as well. And posterior uveitis, which could involve retinal blood vessels, the choroid, and even the optic nerve. And so here's a nice case that's going to take us through some really important concepts in uveitis. So this is a 35-year-old Caucasian man, and he presents to you with a red, teary, painful eye for 2 days. He's got lots of photophobia, which means he's got light sensitivity, and he has significantly blurred vision. So on this diagram, you can see that he's got some mild discharge coming from his eye. So maybe you think to yourself, maybe he has a conjunctivitis, which is pretty common in a family practice or general practice. But hang on a second, he's actually got some layered hypopion, which is these neutrophils and inflammatory cells that are sedimenting down, almost as if the eye was a snow globe and you shook it up and then it was settling down again. And this layered hyphema is at the bottom of the eye, or hypopion, sorry. And then you can see a lot of blurriness of the cornea. So his vision is blurred, and your view of the iris details is blurred because of corneal edema. And then notably, he has a lot of conjunctival injection, ciliary flush, and even some redness or erythema of the surrounding eyelids. This is a very common presentation. Is it just anterior uveitis? Could the back of the eye be involved? Could it be panuveitis? We really don't know until we do a full eye exam. So typically these patients will present to family physicians or emergency departments, and they'll be given topical antibiotics. Sometimes if it's a mild case, it'll resolve on its own. And most times if it's this severe of a uveitis, it probably won't resolve on its own, and the patient will return with a more painful eye and longer duration, and they'll be referred to an optometrist or ophthalmologist for further care. So some of the symptoms of acute anterior uveitis are this really sudden onset, an explosive onset in some cases, and the patient just has a lot of pain, a lot of photophobia and redness, the ciliary flush, which is that redness around the iris. And sometimes on exam under the slit lamp, you can see chorotic precipitates, which are these accumulations, almost like little snow particles on the front of the cornea. There can be a marked amount of cells in the anterior chamber, and even fibrinization or a slowing of the aqueous flow. So when you look in the eye with the slit lamp, you can see the cells in the anterior chamber, but they'll appear to be moving fairly slowly and caught in like this gel. And then the hypopion is evident there. Sometimes patients will present with an unusual looking iris because there'll be synechia or anterior segment adhesion of the iris to the lens, and this causes some abnormal shape of the pupil. And so that's something to look for. Even if you don't have a slit lamp to look at the patient with, you can still identify posterior synechia under some low magnification. And then if you can measure the intraocular pressure, it'll be normal or low, and in some cases it could be elevated with viruses or other infectious causes. So we classify the uveitis as its anatomic location, anterior, intermediate, posterior, or pan, but we can also classify it based on etiology. So whether it's infectious or non-infectious, those are the two main ones that we're concerned about, because that really directs your treatment of the patient. If they have a non-infectious uveitis, they'll require steroids. And if they have an infectious uveitis, you don't want to give them steroids. If the histology is granulomatous or non-granulomatous, that's important to us as ophthalmologists. It helps classify the disease as well. And a good example of granulomatous uveitis that's quite commonly seen in our clinics is sarcoidosis. And the disease course is important too. So if they present with an acute attack, but then they go on to have a chronic uveitis, or if it's recurrent, that gives you some clues as to what the etiology could be. So this patient, on their past medical history, they had no neurological changes, GI, GU, derm changes. They didn't report a history of psoriasis or any other diseases that could be associated with acute anterior uveitis. Specifically, they had no history of JIA, no inflammatory bowel disease, and no ankylosing spondylitis. Their past ocular history was significant for these episodes of conjunctivitis, which were occurring in the last couple of years and treated by the family physician with antibiotics, but they did resolve after 7 to 10 days. The family history, which I'll give you a hint, is very characteristic for patients with anterior uveitis. They usually have a sibling or a family member who has another autoimmune condition. And in this patient, their sister had ulcerative colitis. Nothing significant on social history and no travel history. There was no exposure to TB, which is important in the context of uveitis, and no sexually transmitted infections, also important in the context of uveitis, because we always want to rule out syphilis as a cause because it's a treatable cause of uveitis. Medications, he had none, and he was allergic to sulfa antibiotics. So on your exam, this is what you see. You see stromal edema or edema inside of the cornea, these fine keratotic precipitates. There's a significant amount of anterior chamber cells, 3+ and 2+ flare. And most importantly, we want to rule out any posterior segment inflammation or infections, which could mimic an acute anterior uveitis. A really common one is toxoplasmosis. So in the back of the eye, you'll see a chorioretinal lesion, a scar, or an active area of chorioretinitis, and they'll look like anterior uveitis when they're presenting. They may look like this. So you really do have to do a dilated exam as an ophthalmologist to make sure that nothing is going on in the back of the eye. So in this patient's case, the lens was clear. The vitreous had a few cells, but that's okay because those are just spillover cells. So they're migrating over from the anterior chamber through the lens zonules, which is a communication space between the front and the back of the eye. And they're just spilling over into the vitreous, but there's nothing in the back of the eye to say that they had a vitritis. And then in the retina, there was an obscured foveal reflex and a little bit of swelling of the retina of the fovea. And then the optic nerve was a little bit swollen too, as you can see here. So in ophthalmology, we do a lot of retinal imaging. We do a lot of ocular imaging, and we get to use some really neat technology. Some important information is gleaned from this. So in this patient, even though they have inflammation in the front of the eye, and we're classifying them as an anterior uveitis, they do have some sequelae in the back of the eye. That's okay. It's treatable, and it's not necessarily meaning that we're going to classify it as a posterior uveitis. It's just a sequelae. But you can see here on the OCT, which is a scan of the retina, and it does these fine cuts of the retina and shows them to you in a raster pattern or sequence. There's a little bit of subretinal fluid and some intraocular fluid as well. So that's called cystoid macular edema. And in the context of anterior uveitis, that's going to decrease the patient's vision significantly. Also on the fluorescein angiogram, this is a late phase or late photo of a series of photos that the photographer is going to take when the dye goes in the vein, right all the way through about a minute or two. And then at the end of the sequence, you can see right in the center of the retina, there's that area that's like a petaloid pattern is what they call it. And that's showing the cystoid macular edema as you see it through the eyes of a camera imaging the retina. So on the ocular exam, I would ask you to pay attention to pupils and check for an RAPD or an afferent pupillary defect, because in the context of reduced visual acuity, you want to know if that's a neurological cause or if it's related to the inflammation. And a full dilated exam should be done for patients that have significantly decreased vision in the context of any sort of trauma of the eye, uveitis, red eye, any sort of ocular presentation where that patient's vision is decreased significantly. You're going to want to do a dilated exam, which in your hands means please refer them to an optometrist or ophthalmologist. And when you go through, if you're in the ophthalmology clinic, or if I talk to the residents, I say, examine each part of the eye and think of the possible findings that you might see, because things can get missed easily. So in the context of uveitis and you're looking at the iris, what could you see that's related to uveitis? Well, you could see some nodules. You could see these little swellings on the iris that are called Busaka or Keppe nodules. And that really triggers you to say, okay, this is granulomatous uveitis. not non-granulomatous, so it gives you some categorization of the patient and some clues to their etiology. Going back to the standardization of uveitis nomenclature working group, they showed us that we can divide the anterior chamber cells by grade and classify them 1 to 4. So that helps identify how much inflammation is in the eye. And the way that we do that is, and I wish I had a video for you, but maybe next time we can do low ambient lighting, a small 1 by 1 millimeter slit beam, and you turn up the slit beam to the highest possible voltage or the strongest light possible. And it's a dynamic exam. So you move around the eye and you look for these cells under high magnification. Flare is also possibly graded. It just tells you how much proteinaceous material is in the anterior chamber and how much of the iris details you can see behind it. And that's classified 0 to 4. And this is a good example of anterior chamber cell and flare. So if you're sitting in a movie theater and you have the old projection system behind you and it's projecting onto the screen, it's not a digital system. Through the air in the movie theater, you can see these little particles of dust. And then the air itself, if it's thick or it has a lot of dust in it, you can see that there's something analogous to flare, or that sort of grayish material in the air. So this is, I'm trying to make an analogy to what you see in the eye here in this picture, cells and flare. And then the vitreous haze. So if you do dilate the patient and the vitreous has inflammation, we can grade that, and it's based on how much of the optic nerve you see and how much of the blood vessels you see. And that's graded from 0 to 4, 4 being complete loss of the view of the optic nerve head. So going back to this patient, they do have a significant vision loss. The cause of that is retinal, and so that needs to be treated possibly first with eye drops, definitely steroid eye drops, possibly non-steroidal anti-inflammatory eye drops, and then they may need an injection of steroid in the periocular area to address this if it doesn't resolve quickly. So looking at some non-infectious systemic diseases that can be associated with ocular inflammatory disease. Some of these are common, like for example, multiple sclerosis is fairly common in our clinics, and some things are not common at all. So Behçet's disease, we don't see often. We also don't see cancer-associated or melanoma-associated retinopathy all that often. But JIA, or juvenile idiopathic arthritis, is common, and so is rheumatoid arthritis, and probably the most common are the spondyloarthropathies. Some infectious causes of ocular inflammation you can see listed here and divided into different categories, so viral, protozoan, etc. And of these, I would say the viruses are most common. So herpes viruses, HSV, CMV, and VZV are common. And it's more often that we will test the patient's ocular fluids for these as well. So using a PCR and DNA analysis, we're able to identify viruses as a cause now much more often than we were in the past. Also, toxoplasmosis, I mentioned, is common. It's actually the most common infectious cause of uveitis in North America. And then another common, not so common, but common bacterial infection is syphilis. Lyme disease is quite rare, even though we're in an area in the world where we do have Lyme and we're exposed to it. And then endophthalmitis, thankfully, we don't see often, and it's usually seen after cataract surgery or in very sick patients who are admitted to hospital. So this is a patient of mine whom I've known for nearly a decade now. He's a lovely gentleman, and just by walking in the door, sometimes I'll quiz whoever is with me in the clinic, the resident, and I'll say, what's his diagnosis? And you can see by his very straight spine that he has ankylosing spondylitis because he's in the uveitis clinic. And it's just a clue behind him there is the Newsom-Blatt grading system for vitritis that I just showed you. So all of these clues put together, he's a gentleman with actually chronic anterior uveitis now. And he's on anti-tumor necrosis factor inhibitors, or anti-TNFs, and is doing very well and quite stable on that treatment. But obviously was not able to access those treatments decades ago when they were not commonly used for ankylosing spondylitis, and so he has significant fusion of his spine. So the seronegative spondyloarthropathies are the most common associated with acute anterior non-granulomatous uveitis. And just to give you an idea of that, 70% of uveitis in a community-based ophthalmology practice is related to anterior uveitis and seronegative spondyloarthropathy. So these are the ANK-SPON patients, the Reiter syndrome or reactive arthritis syndrome patients, psoriatic arthritis, and more rarely inflammatory bowel disease. The differential diagnosis of acute non-granulomatous anterior uveitis, like in our patient that we saw, HLA-B27 associated, Behçet's sarcoid, tubulointerstitial nephritis, and uveitis, post-traumatic causes, viruses, syphilis, TB, and then idiopathic is also on the list. And a good number of these patients will be idiopathic after you do a complete set of testing and follow them along and they have further episodes of uveitis. A lot of them are idiopathic, and what that means to us is simply that they don't have a systemic disease associated with their uveitis. So here's a picture of a patient's SI joint fusion and how they present with their typical cases of explosive anterior non-granulomatous uveitis. So we have to remember, though, with autoimmune diseases, we don't always get these clues all together. So sometimes you have to follow the patient in time. Sometimes you make a referral and they can identify some clues with examination of the joints, but they can affect the organs independently. The onset of the eye disease can be before, following, or coexist with the systemic manifestation. And the course of the eye disease doesn't often follow the course of the systemic disease, which causes a lot of trouble in my hands and a lot of hand holding for the patient, actually, because a lot of times we're focusing on treating their uveitis when they have nothing else going on. And their rheumatologist is unable to help other than suggest some possible medications that might have a dual role in treating the eye and the systemic disease. But oftentimes it lays in our hands as ophthalmologists to know what disease matches what treatment the best. And that's where the specialists in uveitis come in, because in a fellowship in uveitis, you'll learn which anti-TNFs go well with which diagnoses and what infectious causes you'd have to rule out before they go on an anti-TNF, and the timing of when we apply systemic medications to patients with eye diseases. Because as you can imagine, it's a bit of a realm outside of an ophthalmologist's typical training to use mostly systemic or oral or injectable or even IV treatments to treat an eye, whereas ophthalmologists are pretty much used to just using drops for treating eye diseases, although that's changing as time goes by. So we also need to know about the course, the severity, and duration. And just keep in mind, all of those things vary by individual. So there's really no pattern that we can identify, not even related to the systemic disease. Sometimes people with AS will have a very severe, long duration of their disease course, and other patients that they see in the waiting room and they'll chat with, well, they'll be like, oh no, I get uveitis maybe once every 2 or 3 years I have an attack. You know, it varies by patient, and that's kind of the goal, is to tailor treatment to the patient. And then not all rheumatologic diseases have the same ocular manifestations, although there's a good laundry list of things that we do for testing and investigation for patients with uveitis. It covers a large gamut and a large spectrum, but not every single form of disease will have uveitis as the relationship. So, for example, when we talk about HLA-B27 related diseases, patients can present with ocular inflammation in the eye, but they can also present with inflammation in other structures as well. So we can have scleritis as a cause of inflammation in the eye. Scleritis can be, is actually a vasculitis type picture of the eye. So It can melt the sclera, or it can cause a lot of nodular inflammation, and it can be necrotizing or non-necrotizing. So some of the common diseases associated here, Sjogren's and rheumatoid arthritis, and necrotizing scleritis is associated primarily with rheumatoid arthritis and other forms of small vessel vasculitis. So when we look at patients with HLA-B27 disease, they'll often present with an acute attack, but sometimes if they're undertreated, or sometimes it's the natural pattern of their disease, they'll move on to have a chronic anterior uveitis. The ones that are more commonly associated with chronic rather than anterior are inflammatory bowel disease and JIA. So I have a case for you of a patient with JIA, and you'll see that it's important that we distinguish acute versus chronic patients. And then panuveitis, the most common patients that we see in our clinic are Behçet's disease. You can also have vasculopathy or retinal vasculitis associated with inflammation in the eye, not necessarily anterior uveitis now that I'm talking about, but these types of vasculopathies are associated with lupus primarily. So when you think of ocular inflammatory disease, I know everybody thinks of inflammation in the eye, but you can have vasculopathy, retinal vasculitis, inflammation of the blood vessels without intraocular inflammation. Not a single cell would appear in the anterior chamber or in the vitreous. So again, I would emphasize that when we think of those diseases, it's primarily lupus that does that. Antiphospholipid antibody syndrome is another one that will cause retinal hemorrhages and vasculitis. And then Behçet's disease commonly has both intraocular inflammation and vasculitis associated. And giant cell arteritis can cause uveitis, but it more commonly causes a vasculitis of the optic nerve or an optic neuropathy, as well as antiphospholipid antibody syndrome as an autoimmune cause. And then I spoke a little bit about how uveitis encompasses orbital inflammation. So we sort of cross paths with our oculoplastic and orbital colleagues on some of these patients where they may have ANCA-positive vasculitis or GPA, and they'll have these terrible attacks of orbital inflammation with lots of pain, proptosis or swelling of the eye where it pushes forward and the extraocular muscles are involved as well. It may even cause a compressive optic neuropathy, which is visually threatening for the patient. So these patients are automatically put on high-dose IV steroids and long-term prednisone. But in my hands, I can help my colleagues because of using medications like anti-TNFs or immune suppressants like methotrexate and Cellcept to help treat these orbital conditions. Patients with scleritis can also present with a minor form of inflammation of the episclera. So sometimes this is more associated with certain diseases like peripheral ulcerative keratitis. Episcleritis and scleritis go hand in hand. And many of these patients are have limited inflammation to the front of the eye. So they'll have an anterior scleritis, and that can present as diffuse redness or a nodule or necrotizing inflammation. And then in some cases, they don't have inflammation in the front of the eye that's visible. They have posterior scleritis. They'll have a similar amount of pain. They may have difficulty with extraocular movements or diplopia, and they may be discovered to have swelling of the back of the sclera called posterior scleritis. And scleritis is a very painful condition. Typically, it radiates all the way across to the back of the head, sometimes to the jaw, and sometimes to the ear, and usually wakes the patient up from their sleep. It's very painful, except the type of scleritis called necrotizing scleritis, which is not painful without inflammation or scleral melting. Generally, the thankful thing about scleritis, it doesn't affect vision, but it can be complicated by other things like glaucoma, cataract, and corneal involvement. And oftentimes, scleritis affects patients with rheumatoid arthritis. And so it's an older group of patients that present with this disease. And so it's something to be alerted to if you have an elderly patient with a lot of pain and redness of the sclera and a history of rheumatoid arthritis, for example. In fact, if you take the group of patients with scleritis, half of them have an associated systemic condition. And of that half, the systemic condition, half of those are rheumatoid arthritis. So that's really predominantly a significant association with scleritis. And the others are usually Sjögren's or small vessel vasculitis or GPA. So this is a picture of necrotizing inflammation and non-necrotizing inflammation. So you can see the difference. The top photo has a scleral melt, and there's an avascular zone of the sclera, and there's even a patch that's really thin. And you can see that purple hue underneath, and that's the uvea underneath there. So it's very close to the retina. They're at a bit of a higher risk of perforation of the eye if they have such a thing. And then below is non-necrotizing scleritis, and it's a large swollen area of sclera. Posterior scleritis is the least common, and it's probably underdiagnosed. And you can see a lot of intraocular clues with choroidal folds, subretinal fluid, or optic nerve swelling, and sometimes elevation of the choroid. And on the ultrasound, there's something called the T sign, which is where you have a cleft of fluid behind the sclera, and it causes a T with the optic nerve behind it. And this is a patient with episcleritis, so they don't have a significant amount of scleral inflammation, but they do have a patch of dilated vessels on top. And so you can move this with a Q-tip, and if you put a drop of anesthetic in the eye and you take a Q-tip, you can actually slide this along the top of the sclera, and the sclera is not affected by this. They usually present with a hot, prickly sensation in the eye. It's uncomfortable, but it's tolerable. It's not at all like scleritis. Doesn't wake them up at night. And in fact, it self-resolves in most cases without any drops. Oral NSAIDs can be useful for this, as well as like low-dose topical steroids. The other clinical clue to episcleritis versus scleritis is that oftentimes the blood vessels have a radial orientation, and oftentimes they're along the path of one of the extraocular muscles, like the medial rectus or lateral rectus. It's commonly mistaken for conjunctivitis. And really, there should be no anatomical change. So no change in vision, no discharge. They can have sometimes a little light sensitivity if they have dry eye symptoms, but really shouldn't have a change in vision. And it's not at all a threat to the eye. There's no permanent ocular damage. What is a lot more severe is peripheral ulcerative keratitis. So patients with rheumatoid arthritis and other rheumatologic conditions, even HLA-B27 disease can present this way, but it's rare. Giant cell arteritis can present this way, but it's rare. And it can be associated with inflammatory bowel disease. So these types of patients who have other autoimmune conditions can have this melting of the peripheral cornea, and it can cause significant vision loss and corneal perforation. And oftentimes it's hard to treat. Sometimes steroids don't touch it, and they require a lot of immune suppression to keep it under control. If they have orbital inflammation and they're ANCA positive, this is GPA until proven otherwise, and also rheumatoid arthritis is a very commonly associated condition. So other signs and symptoms of eye inflammation that would be helpful for you, I think, to review are this concept of ciliary flush, so that ring or circumcorneal edema and ciliary flush that we see often in anterior uveitis. A band keratopathy is probably something you need a slit lamp to see, but this is calcium accumulation in Descemet's membrane, and it happens with chronic uveitis. For example, kids with juvenile idiopathic arthritis who have really, really insidious uveitis, and it's not caught unless it's being screened for, and sometimes they present with complications, and they present perhaps with decreased vision from this layer of calcium across the cornea. We talked about peripheral ulcerative keratitis. It can cause a bit of a diagnostic dilemma in some patients where it looks like an infectious uveitis at the beginning before it melts the peripheral cornea. And this is a patient with inflammatory bowel disease who has multiple areas of peripheral ulcerative keratitis that look infectious. When we spoke about granulomatous versus non-granulomatous inflammation, you can see the difference there is just the larger patches of cratic precipitates. And then the non-granulomatous type is just a little bit of smallish accumulations of neutrophils and inflammatory lymphocytes on the back of the cornea, but there's no standardized grading system for this. Sometimes it can be confusing because if you do look with a slit lamp, you can see these pock marks on the back of the cornea, and that's simply hyalinization of the corneal endothelium from previous ceratic precipitates, but there's nothing active going on. We talked about posterior synechia and how the pupil can look abnormally shaped. And this is more of a cosmetic problem for you and the patient. So when you look in, it looks not very nice. The patient can notice it, but it very rarely does any damage to the vision unless it's very small and the pupil gets very, very small. This is the Kepe and Busaka nodules that we spoke about. And iris bombay are sort of a pushing forward of the iris due to an abnormal or poor communication of fluid between the front and the back of the eye, which can cause an acute glaucoma. And also optic nerve or disc swelling can occur with uveitis, and that can sometimes be very subtle, but it can occur, for example, with lupus-associated diseases. And this is a patient with Behçet's disease who has oral ulcerations, retinal vasculitis, and acute anterior uveitis as well. We can see in the back of the eye some abnormal blood vessels growing. So in a patient with sarcoidosis, for example, you may see these marks at the bottom of the eye called multifocal choroiditis. They can have a lot of optic nerve changes, including neovascularization of the optic nerve. They can have accumulations of inflammatory cells along the blood vessels, and they can get very thick and cause something to look like candle wax drippings, or it looks like that material is accumulating and dripping off the blood vessels, hence the name candle wax drippings. And then you can see a nerve fiber layer infiltrates or cotton wool spots and hemorrhages, and that's a sign of occlusive vasculopathy typically, or microangiopathy. And then patients with complete occlusion of the blood vessels can have branch vein occlusions or branch artery occlusions, like this patient with lupus. So in terms of classification, we talked about onset, duration, course, and this is exactly how we classify it according to the Sun descriptors. The key to remember here is the 3-month mark. So if the patient has less than 3 months duration of uveitis, it's limited, but persistent would be more than 3 months duration. And that also comes into play when we consider patients with chronic uveitis. So if they've had persisting uveitis with relapses, and their relapses are very short, the short duration in between the relapses occur, it's chronic uveitis after that. Chronic uveitis can present with painless vision loss, blurred vision from complications such as cataract or macular edema. And then intermediate or posterior uveitis, patients can have floaters. They can see things floating in their vision. And when we look in the eye, we can sometimes see vitreous opacities or snowballs in the vitreous. They can have changes of the vision described as metamorphopsia, so a distortion of vision, scotomas, or even night vision problems such as nyctalopia. So what to do with our patient then? This patient has anterior uveitis with posterior segment sequelae. We've categorized them. We now need to investigate them. So diagnosis can be established in about 70% of uveitis with a detailed history, an eye exam, and ancillary investigations. And a large number of patients are classified as idiopathic even after testing
So I think Dr. Gottlieb may have some connectivity issues. We'll give her a few moments here and see if she's able to get her internet back. Um, for those of you not in Canada, we're coming from Ottawa, and the rain there has been pretty intense lately. And so we'll give her a few moments here and see if she's able to get back online. So while we wait to see if Dr. Gottlieb can join us, I'll just wrap up here by sharing a few of our last housekeeping things here. And maybe our VISCO team can announce the winners of the Kahoot while we go through some of this. And so just for those of you who joined a bit later, COSIG is recruiting an international representative. So for those of you who are from a non-Canadian medical school and are planning to apply to a Canadian residency program, we'd welcome your applications here. And just a reminder about the post-CARMS talk. And so this will feature over 10 recently matched ophthalmology residents who are in their first year of residency, who will be sharing some tips about that residency application process and how they're enjoying their first months of residency here. And just to build off what Dr. Begg had mentioned at the start of the session, there is a in-person conference in Ottawa that we wanted to mention called the Sally Letson Symposium. And so this is in person, it's a COS event and is meant for not only practicing ophthalmologists, but there's also a large portion of the event that is focused on trainees. And so residents and medical students are welcome to attend. And so if you shoot up online, registration is open. And so it's a nice in-person event and you get a chance to engage with some local ophthalmologists, not only in Ottawa, but there's many attendees from across Canada. And so finally here, we do have our post-session survey. And so, we'd welcome you to fill this out, both for Dr. Sabetti and for Dr. Gottlieb, to share some feedback on how you found the sessions and whether you found the content helpful or not. And so we'd welcome your feedback there. And so I'm just going to see if Dr. Gottlieb was able to get back online. But, if not, we'll touch base with her. Thankfully, she was near the end of her presentation before we ran into some weather-related technical difficulties. And so, I'll ask her after the session if there's any closing thoughts she wanted to share with the group, and we'll distribute that either as a email, or we may record a short sort of closing segment that'll be attached to the recording of this session that's posted online. And finally, I just wanted to thank you all for joining us for this year's edition of VISCO. I hope you all learned something about ophthalmology and have something that you can apply to the rest of your medical education, to your upcoming clinical electives, or to your residency training. And so if you found this course helpful, we would really appreciate your feedback so that hopefully we can bring this course back next year and make it even more informative for you all. And so with that, I'd like to thank you all for spending your Sunday afternoons with us, learning about ophthalmology. And I really hope to see you all at future COSIG events. So thanks so much, and I hope everyone enjoys the rest of their weekend.